Thank you, sir. So as I was saying, she presented to our OPD with chief complaints of bleeding per vaginum since 15 days. History of presenting illness. Patient attained menopause 6 years back after she took medications which is prescribed by a doctor for complaints of recurrent episodes of excessive bleeding. This excessive bleeding was sudden in onset, it was profuse, and it lasted for 4 to 5 days continuously, and it recurred every 15 days. And she noted this pattern for a month. She took the medicines prescribed for 10 days, following which she recovered completely symptomatically. Patient was apparently normal until 15 days back when she developed excessive bleeding again, which was sudden in onset, continuous, moderate to heavy blood flow, associated with intermittent release of white sevous discharge. The patient gave history of changing 2 to 3 pads per day.
Okay.
11 days back, she consulted a doctor at Hassan who gave her some medications for 5 days. She was also referred to a higher referral center for further evaluation. The patient reported that while she was referred to our hospital, which is a higher referral center, she reported that on taking these medications, she saw a reduction in her symptoms, that is, bleeding reduced. There was no history of trauma or surgery, no history of pain abdomen, fever, weight loss, no history of altered urinary or bowel movement, no history of pain during defecation or bleeding to rectum, and no history of previous cancer screening.
Okay, Padmavathy, can you just tell me these negative histories? What is the significance of each of these histories that you've asked? Why have you asked no history of trauma or surgery? Just each one of them, can you just briefly tell me why you've asked these?
Yes, ma'am. So maybe if she had any surgery, there could have been damage to the uterine or the adnexa, which can cause the bleeding. Or if there's any history of trauma or foreign body, and it was evacuated and treated, like subsequently managed with packing or something that could have.
What surgery would you in particular ask?
C-section, ma'am.
Why would you expect a cesarean section to cause postmenopausal bleeding?
Maybe because of scar rupture in the later years.
A scar rupture will present. How will a scar rupture present? Will it present as intraperitoneal bleeding or vaginal bleeding, or both? And why will it present in the postmenopausal age group? When do you see scar rupture? If a patient has a previous cesarean scar and previous cesarean done, when will you expect the scar to rupture?
Ma'am, maybe after, I think, a few months post-delivery, ideally.
So the scar, if a patient has a previous scar, you will expect the scar to rupture during a pregnancy. That is when the uterus is distended. Okay, without any reason, the scar will just simply not give way. Okay.
Okay, ma'am.
Okay. What surgery would you ask in this patient?
Appendicitis, maybe.
Why will appendicitis cause postmenopausal bleeding? I'm asking you because you've asked this negative history. So you must have had something in mind when you asked this. What are the causes? Okay, so indirectly, basically, I'm asking, so a patient has come with postmenopausal bleeding. So indirectly, I'm basically asking you what are the causes and how will you rule out each cause based on history? Right? So trauma is okay. I understand trauma. I understand foreign body. But surgery, I want to know which surgery would cause postmenopausal or which would present with vaginal bleeding.
Ma'am, maybe also a malignancy, surgery for a malignancy.
Okay.
Of malignancy.
Okay. So basically you want to ask if she's had any vaginal surgery. Okay, yes, whether maybe she's had a biopsy, maybe she's had a vaginal hysterectomy, or maybe she's had a cervical biopsy. Okay, so any vaginal surgery is what you would look for. Okay, and this is a rare cause. So this I would put in the last. I would ask the more common things first. Okay, why have you asked pain, abdomen, fever, and weight loss? Put them all together.
Ma'am, to rule out pyometra.
Okay. Pyometra, how will pyometra present as? Will it present as postmenopausal bleeding?
Ma'am, mainly pain abdomen.
Okay. What else?
Fever also, ma'am.
Okay. Right. So what are the causes of pyometra? What can cause both pyometra and postmenopausal bleeding?
Ma'am,
So you're right. You look for pyometra. You've asked this patient the history, thinking of what?
ma'am, I thought along the lines of infection.
Of what?
Infection.
I didn't get you. Okay, so Tanvi's answer, Tanvi's replied, cancer cervix. Yes, so cancer cervix can present. So think of common things first, right?
Okay.
Your main worry in a woman with postmenopausal bleeding is what? What is your main worry? Why are we so concerned if a patient comes with postmenopausal bleeding?
Cancer, ma'am.
Cancer, yes, very right. So,
Hello.
that's why we need to evaluate the patient. You can't just leave her alone. Okay, and the most common cancer we know is of the genital tract is cancer cervix. So,
Yes,
how
ma'am.
does cancer cervix present? What are the symptoms of cancer cervix?
Ma'am, maybe presence of a mass or a lump in the cervical area, or there could be family history of cervical cancer,
Yeah.
or there could be generalized symptoms like
What are the symptoms of cancer cervix? Common
ma'am,
symptoms.
weight loss and bleeding.
Okay,
Weight
weight
loss.
loss, bleeding. So abnormal uterine bleeding. Yes. What else?
Ma'am, sensation of a lump.
Okay, more than lump, what will the patient have? So when you say abnormal uterine bleeding, what kind of abnormal uterine bleeding will a patient with CA cervix have?
Ma'am, menorrhagia.
More common than menorrhagia? Okay, so what is menorrhagia?
Ma'am, menorrhagia is excessive volume of blood, ma'am.
That's it. Anything else? Do you want to complete the definition? Excessive bleeding, which is either prolonged in duration or in amount in a regular cycle or an irregular cycle.
In an, I think regular, ma'am.
In a regular cycle. So menorrhagia, the definition always is in a regular cycle. All right. So in
Yes,
CA
ma'am.
cervix, what will you expect? Will you expect?
I think, ma'am, maybe polymenorrhea, maybe not menorrhagia, but
Okay, what else? Tanvi, can you tell us what are the other symptoms? What are the abnormal uterine bleeding patterns in CA cervix?
Ma'am, metrorrhagia, dysmenorrhea, and ma'am, postcoital bleeding if she is sexually active.
Okay, so postcoital bleeding and intermenstrual bleeding is what they will mainly present with. Okay, and even postmenopausal bleeding, like this patient. Okay.
Yes.
So these are the few things you will look for. Okay, continue.
Ma'am, yes, ma'am. So, no history of altered urinary or bowel movements. I'm thinking of if it is also affected adnexal structures, like adjacent structures, ma'am. Maybe if it's a tumor, it could have metastasized to the adjacent areas.
Okay, all right.
And no history of pain during the defecation or bleeding for rectum. I'm ruling out other cause, like non-uterine causes of bleeding, like hemorrhoids
Okay,
hemorrhoids or anorectal seizures.
all right.
And no history of previous cancer screening to see if she's had any past history of pap smear
So
screening
you've said,
for.
okay, so you've said previous cancer screening. What are the routine cancer screenings we do in our setups in our country?
Ma'am, pap
I'm
smear.
talking about gynecological cancers, obviously. Yes, pap smear we do. How often do we do a pap smear? What is the recommendation? How often should we do? And how should we do cancer cervix screening?
Ma'am, you should only do if there are risk factors like family history.
Should we do it in every woman? In which kind of women? How often should we do? Should we do only a pap smear or can we do something else? So remember, every word that you say in your history, okay, you should be able to justify why you asked this, and you should be able to answer why you asked this, okay, or related to it. Okay, so everything you put down, okay, in writing, you should be able to have or understand why. So it's good you've asked, but now so the topic can go, the discussion can go anywhere. The topic is postmenopausal bleeding, but the examiner can ask you on completely change the path and to take you on a path of cancer cervix screening. So you should know about cancer cervix screening. In which women do you do it? Anyone can answer? Tanvi?
Those with history of family history of cervical cancer or
Only family history, or you'll do it for
family
all
plan,
women?
all women.
Go
All
for
women, which age group, which
reproductive age group.
pardon?
any woman who is sexually active within 3
Okay.
years. You can start with cervical screening, and
Okay.
it includes pap smear. And also, if the pap smear is abnormal, we can go for the HPV testing in the earlier
Okay.
age group. In later cases,
Okay.
if the high risk patients are present, if it is means it shows the high grade SIL, and means if it is third category from low grade SIL, high grade SIL, in those cases we can directly go for apart from pap smear, directly HPV testing
So
can be
we
done.
can do directly. So that's what I'm saying. So the WHO now says you should screen every woman after they're sexually active every 3 years if you're doing a pap smear, or every 5 years if you're doing a co-testing. What is co-testing? It is both pap
Both
smear
pap
and HPV screening. And it has also said the ACOG has said you can replace pap smear with only an HPV. Okay,
Okay.
so both PAP or an HPV or both, and you do it in all women. All women who come to the OPD, it is an opportunity to screen them for cancer cervix. Okay, remember this. Once they're sexually active, every 3 to 5 years till the age of 65 years, all women should be screened for cancer cervix. Okay. Do we
Yes.
routinely screen for the other gynecological cancers?
No, ma'am.
What are the other gynae cancers we know of?
Endometrial,
Yes,
ovarian,
endometrial and
ovarian.
fallopian tube,
ovarian. So the three most common cancers are cervix, endometrial,
endom,
and ovarian.
ovarian.
Okay, so these three you should remember, but we don't screen for endometrial and ovarian for all women. It is only a high risk screening group we do.
Yes.
Okay, but universal screening for CA cervix. Remember this. Okay.
Yes,
Okay,
ma'am.
continue.
Yes, ma'am. Okay. Yes, ma'am. Menstrual history, she attained menarche at the age of 15 years. She attained menopause at the age of 42 years.
Why is this
Last month,
relevant? Why is this relevant?
ma'am, because in certain cancers, if there's delayed age of menopause, it predisposes to them getting the cancer. Like in endometrial cancer, if the age of menopause is beyond 52 years, she is at a higher risk of developing
So
cancer.
early menarche and late menopause means more estrogen exposure. More estrogen exposure means higher the risk of endometrial carcinoma. Okay. And hyperplasia. Okay. Continue.
Also, ma'am, CA cervix has a bimodal age distribution, so
Yes.
the presentation can be very early or it can be very late as well.
Right. Okay. Okay. Continue.
Last menstrual period date not known. Premenopausal cycles were normal and regular, occurring every occurring every 27 days. Bleeding lasted for 4 to 5 days, and she used 2 to 3 pads per day. No history of dysmenorrhea, passage of clot.
Okay.
Can I continue, ma'am?
Yeah.
Okay. Obstetric history, married life of 30 years. She has married life of 30 years, and it is a non-consanguineous marriage. Her obstetric score is para 2, living 2. Spacing of birth between the first and second child is 2 years. First pregnancy, she delivered a male child, and it was a normal vaginal delivery at home conducted by a midwife. Birth rate of the first child was 2.5 kg.
You can skip this. You can skip this. Next slide.
Okay, ma'am. Past history, patient is not a known case of diabetes, mellitus, hypertension, TB, asthma, or any other chronic illness. Patient had complaints of excessive bleeding every 15 days, 6 years back, for which she took certain medications prescribed, following which...
You didn't tell this in the menstrual history. Isn't this important? In the menstrual history, you said she had regular cycles.
Ma'am, I said yes, ma'am, but I also mentioned it in HOPI. So should I mention it in
But you
menstrual?
have to mention this in the menstrual history. This is a very important history. Why is this an important history?
Ma'am, because it gives a history about use of certain medications and about her attaining menopause and also about the irregular bleeding, ma'am, like perimenopausal bleeding.
Why is it important now? 6 years back, she had heavy cycles.
Yes, ma'am.
So how does it matter?
Ma'am, there could have been a history of endometrial hyperplasia due to some cause. She might have got tested.
Very good. So endometrial hyperplasia could have been there, which was not diagnosed, and now she has progressed to endometrial cancer. Okay, you've written history or no history of screening for cervical or breast cancer. Suppose she had a history of breast cancer. Would that be relevant?
Yes, ma'am, I think so.
Why? Suppose she says I was treated for breast cancer 10 years back. Is that important now?
Yes, ma'am.
Why? Tell me two reasons why it's important.
Ma'am, because
and she comes now with this history.
Ma'am, because breast cancer, if she was screened and she was diagnosed to have it, she would have been given, should have been put on medication.
Which medication?
HRT, I think, hormonal replacement.
Which medicine are we looking for? Which name? Tamoxifen. Why tamoxifen? Why am I worried that she's on tamoxifen?
Ma'am, there's prolonged estrogen exposure.
Causes endometrial cancer. Right. So tamoxifen is known to cause endometrial cancer. Okay.
Yes, ma'am.
Yeah. Okay. Continue.
Okay. This is family history. There is no history of breast or endometrial carcinoma among the family members. No history of bleeding disorders among family members. No history of hereditary non-polyposis colorectal carcinoma among family members.
Ma'am, excuse me, can I ask something?
Yeah.
Ma'am, breast cancer, does it have a relevance of genetically related disease to endometrial?
Yes. So genetic. So you have both BRCA1 and BRCA2, ovarian cancer and breast cancer, but also endometrial cancer is at a higher risk. Even Lynch syndrome. Okay, so all these have association of endometrial cancer and breast cancer. Of course, ovarian cancer is more common with BRCA1 and BRCA2, but also endometrial cancer.
Okay. Yes.
Next.
Continue.
Yeah.
Okay, personal history, her diet is mixed. She has a good appetite, she has undisturbed sleep, her bowel is normal and normal movements, and bladder habits are normal and regular. There is no history of ill habits.
Okay.
So at the end of history, we can summarize it as follows. Mrs. V, age 48 years, with obstetric score of para-2 living 2, is a postmenopausal lady with a past history of excessive bleeding before attaining menopause, who came to the OPD with complaints of postmenopausal bleeding for further evaluation.
Okay. So what will you think of? What are your differential diagnoses now, based on this?
Yes, ma'am. Based on this differential diagnosis, I'm looking at fibroid uterus or any carcinoma. It can be endometrial.
Why fibroid uterus? And if fibroid uterus, which kind of fibroid uterus?
Ma'am, fibroid because she presents with history of excessive bleeding. Like her current complaint is bleeding per vagina.
She is complaining of postmenopausal bleeding. So which kind of fibroid will cause postmenopausal bleeding?
Ma'am, I think
because you said fibroid. Do fibroids commonly present with postmenopausal bleeding?
No, ma'am. It's commonly in the
Why have you put it as your first differential diagnosis?
Yes.
What should be your first differential diagnosis?
Ma'am, any carcinoma, maybe endometrial.
Okay. Endometrial carcinoma. Which other carcinoma?
Ovarian.
Cancer.
Ovarian. Okay. More common than ovarian. Why will ovarian cancer cause postmenopausal bleeding? Which type of ovarian cancer will present as postmenopausal bleeding?
Granulosa cell tumors.
Yes,
Granular.
granulosa thicker cell tumors can present as postmenopausal bleeding. So I will put that lower in the list. My topmost would be endometrial cancer or endometrial hyperplasia maybe, but even higher than that. What is the, in other words, I'm asking what is the most common cause of postmenopausal bleeding?
Senile endometriosis.
Wait, let her answer, let her answer.
Um,
I put this on my YouTube also today, the question.
I answered that, ma'am.
Yeah, I saw. Which is the most common cause, and this is a neat PG question, which is the most common cause of postmenopausal bleeding. And that is why it should be the first differential diagnosis.
Ma'am,
I'll give you choices. Endometrial, okay, she told the answer. So it's endometrial atrophy. Okay, so a thin endometrium. What happens in the postmenopausal age group? The endometrium becomes very thin. So the capillaries beneath are they easily break out. So that's why, but the another thing which doesn't fit with this patient's symptoms are senile endometritis or atrophic endometrium will cause spotting or mild bleeding. It is very unlikely to cause heavy bleeding like in this patient. That's why maybe endometrial pre-malignant lesions or cancer, maybe I would put above endometrial atrophy in this patient. I will also like to put cervical cancer also as a differential diagnosis. Okay.
Okay, ma'am.
Again, but that question remains, which kind of fibroid, Tanvi, which kind of fibroid can present like this?
Submucous.
A submucous fibroid which has undergone necrosis, or a fibroid polyp, okay, which is hanging outside and its surface has got eroded, can present with bleeding like this. Okay, continue. Do we have any significant examination findings? Directly go to any significant examination findings.
Okay, ma'am.
Anything, just tell me your main findings. Is there anything you found?
Yes, ma'am. External genitalia is normal, but vagina was dry, inflamed, less rugged.
You did a speculum and a PV, very good, because we don't expect undergraduates to do, but if you've done, very good. Cervix was healthy, os was stenotic, bleeding through os present, no difficulty exposing cervix through upper vagina. What does this mean?
Means there's no stenosis of os, ma'am. The cervical os is not.
Okay, so the cervix was normal, the uterus was normal, everything looks normal, right?
Yes, ma'am.
Now further narrow down your differential diagnosis. Everything looks normal. So what can we rule out? We have made a list of endometrial atrophy, endometrial hyperplasia, endometrial malignancy, fibroid, and cancer cervix, right? Which ones can I remove based on your examination?
Ma'am, cancer cervix can be removed.
Cancer cervix I can remove. What else can I remove? Uterus is normal size. There's nothing seen outside the os.
Fibroid can be
also remove fibroid, because if it was a submucous fibroid, the uterus should have been enlarged, regularly enlarged. Or if it was a fibroid polyp, I should have seen something coming out of the os, right? So now we are left with endometrial atrophy, endometrial hyperplasia, and endometrial malignancy. So how will you want to proceed further?
Ma'am, I think further we should go for investigation.
Yes, I know. That's what I'm asking. Which investigation?
And ma'am, endometrial biopsy.
Directly, or do you want to? Okay, so if you are in the UK or in the US, I would have said yes, you will do an endometrial biopsy. But which cost-effective investigation can we do here before doing an endometrial biopsy?
Sonography.
USG?
Yes, an ultrasound. We can do a transvaginal ultrasound because it's the uterus is small, it's a pelvic organ. What do I want to see in the ultrasound?
Ma'am, we will look for presence of any polyp in the uterus.
Okay. Polyp, what else?
Endometrial thickness if it's greater
Yes,
than 4
very
to
good.
5
So an
mm.
endometrial thickness will tell me if it is a atrophic endometrium, if it's very thin, or whether it is a hyperplastic endometrium, if it is thick. So what is the cutoff we take? Post-menopausal, what should be the endometrial thickness?
Ma'am, 4 to 5 mm if it's
Yes, it
beyond
should
that.
be less than or equal to 4 mm. 5 mm or above, we consider it abnormal and we can do a biopsy if it is more than 5 mm. Less than or equal to 4, we can leave her alone. But if she's having repeated episodes of bleeding, then again we do an endometrial biopsy. So I want to take a short session because I have actually 2 or 3 patients waiting for me. So I just want to ask you, endometrial biopsy, how will you take? What's the different ways we can take an endometrial biopsy?
Ma'am, we can do a differential curettage.
We can do a
Differential curettage. Hello.
What is? Now tell me again. What curettage?
Fractional curettage or
Fractional.
dilation?
Okay, right. So
Okay.
you said we can do a dilatation and curettage, or we can do a fractional curettage. What is the difference between the two? DNC is dilatation and curettage, and fractional curettage. Tanvi, what is the difference?
Ma'am, in fractional curettage, it is also obsolete now. We used to take 5 places, different places for biopsy. Dilation curettage, normally we dilate the cervix before taking the curettage. But ma'am, we can, in this case, we can go for an office biopsy with a pipelle as well.
Right. So basically, when we take a biopsy, we can use different methods. Okay, so one is so to take a biopsy, you have to first dilate the cervix, and then only the curette can be introduced, so we can curette the endometrium. So we can do a dilatation and curettage, or we can do a fractional curettage. The basic difference is, Padmavathy, is a fractional curettage, you're also taking endocervical biopsy.
Okay.
You're first taking an endocervical biopsy, and then you're dilating the cervix, and then you're taking an endometrial biopsy. So this, you ensure you're not missing an endocervical lesion. Okay, so you're taking 2 biopsies mainly. Okay. But yes, what is the gold standard? What is the best way? Both these procedures involve dilating the cervix, which is very painful. And we just want an endometrial biopsy. So what is the best way to do this? What is the gold standard? Somebody asks you, what is the gold standard method of taking an endometrial biopsy?
I'm using a pipelle office.
Cannula.
It's not gold standard. Gold standard is a hysteroscopic guided biopsy. What is a hysteroscopy? What is a hysteroscope, Padmavathy?
Ma'am, this is an instrument used to view the
visualize the inside of the uterine cavity. Okay, like a laparoscope. This is a hysteroscope. So we distend the uterus with fluid, and then we put in a scope and we see the uterus, see if there's any polyp or any abnormal area, and take a biopsy from there. Okay, or as Tanvi said, in the office, in the OPD, we can do a endometrial biopsy just using a simple pipelle. What is a pipelle? A pipelle is a very thin cannula which doesn't require dilatation of the cervix. Okay, there are different types of pipelles or disposable cannulas which are available, and it doesn't require dilatation, so it is not painful. It is an OPD procedure. Okay, so these are the different ways we can take an endometrial biopsy, and this patient does require an endometrial biopsy because she has repeated episodes of postmenopausal bleeding. She has a history suggestive of endometrial hyperplasia because of her heavy bleeding before menopause. Okay, so we can't leave her alone. We have to evaluate her. Do you have any idea what happened to this patient? What was done for her?
Yes, ma'am. Her sample was sent for biopsy, and the report came as she was diagnosed with stage 1B endometrial carcinoma.
Okay. What is stage 1B endometrial cancer?
Ma'am, stage 1B is the tumor is confined to the uterine cortex, but the myometrium invasion is more than half of the.
Okay, so is it a surgical staging or is it a clinical staging, endometrial cancer?
Surgical staging, ma'am. What I meant.
Surgical staging. So if she was diagnosed with 1B, what is the treatment of choice?
Ma'am, surgical management.
What will you do in surgery?
Hysterectomy.
You will do a total abdominal hysterectomy with a bilateral salpingo-oophorectomy. So as a final year student, you should have your answers very complete. Okay, if
Okay.
somebody says hysterectomy, you're not wrong. But if somebody says total abdominal hysterectomy with a bilateral salpingo-oophorectomy, the examiner will be happier. Okay, so you have to
Okay.
make the examiner happy. Okay, so that you get more marks. Okay,
Yes.
you answered well, you presented very well. Okay, but you need to concentrate on two things, Padmavathy. Number one, you need to think about common things. You're thinking of rarer things more.
Yes,
Okay, so
ma'am.
this comes with experience. Of course, you're not in practice, you don't know what is commonly seen, but always think of common things. Okay,
Okay.
don't think of rarer things first. Whenever you answer, when you make your differential diagnosis, your diagnosis, think of what things you will do or what things will present commonly. Okay,
Okay.
otherwise your presentation was very good. I'm
Okay.
sorry I have to take a shorter session because I have some patients waiting in the OPD. But thank you very much. Thank you, Tanvi, also for contributing.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
I think we can stop the session. Is anyone there from the White Army? Okay, so I'll only close the session then. Thank you, everybody, for attending. And I am glad to be part of such presentations. I'm looking forward to more presentations. Padmavathy, you can check out my YouTube channel. You'll find a lot of hysteroscopy videos and discussions on this topic itself. Okay, so you'll
Sure,
understand it
ma'am.
better.
Sure, ma'am, I will. Thank
All
you. Thank
right.
you so much.
Okay.